All right, looks like we're live. Dr. Salka and everyone, welcome. If you're just logging in here, you're at Optometric Education Consultants, bringing love back to the visual field. Looks like we have about 72 of about 110 people getting here. So let's give it a minute too. So Joe, we're gonna, before I do some housekeeping, do you want to take care of that polling question? People that are out there, make this live and interactive. We'll warm up. As you'll see on your right side, you'll see polls. If you click on that, we're going to launch a polling question here.
All right. We're going to get started because the polls are important for COPE and getting the COPE approval. So I'm going to start the poll. And this is just a test. How is your practice doing with COVID-19? Is it closed? Is it open for urgencies and emergencies only? Open with a very reduced schedule, or open almost back to normal? All right.
There we go. Got some answers rolling in here.
Good. We're getting in there, getting a few people. Give it another second or two. All right. And I want to show the results. Well, most people are almost back to normal, or open and back to normal, open and busier than before COVID-19. Only very small, open for urgencies and emergencies.
That's pretty awesome, because we've been doing these since April now, Joe, and we've kind of seen that kind of shift down. It was majority closed and open for urgencies. That's great to see optometry out here getting taking care of the people like we should. All right, so we're going to get started here very shortly. Got some housekeeping. I'm actually going to launch my handout. I'm going to share it. I have two handouts to share. They're actually the full slides if you want to download that. So there'll be however many slides I have, 40 some slides, or you can have the 6 slides per page, or both. I just launched them. You should be able to see them and download them, and then you can make reference to them now or later as the presentation goes on. We went through the polling questions. This course is being recorded. We've been being recorded since the beginning. There'll be a replay sent tomorrow, about 14 hours after the webinar ends. It gets sent tomorrow along with a survey. However, that replay, you'll need your unique password, and that does have an expiration to it. So I will eventually get this and put it on our YouTube channel. So YouTube channel, if you guys are familiar with that, all the other webinars are up there also. It's just Optometric Education Consultants. Just go ahead to it, and you can watch all the webinars and even the replay of this one once I get it downloaded and on there. There will be an email sent in about an hour after this webinar is over. Please complete that. You'll get another email tomorrow from us with the replay from Webinar Jams, and then you can watch it there, and there's also the survey there also. But again, we can put it on our YouTube channel, and I'll have it up there in about a day or two. The best thing that you can do to help your experience out, this is a cloud-based webinar. So if you can decrease your bandwidth at home, close all application, Wi-Fi, gaming, children playing Xbox, spouses watching movies off of iPads on Netflix, that competes for your bandwidth at home and can interfere with this. It might ask you to reconnect. You don't have to do that all the time, but if you do get disconnected, just reconnect. Questions will be in the chat box. Joe, looks like there's something in there now. I'm not sure if this people are replying to the poll, but Dr. Salka, because I'm going to go to my screen will get hidden as I do the presentation, so Joe can weigh in with questions as you guys put the questions in. Last thing, Vanessa is our conference coordinator. She will send information to Arbo for you if you gave us your OE tracker number. So she'll put that information. That is taking 7 to 10 days turnaround. So I'll get her the information tonight or tomorrow. She'll generate a report, get it off to Arbo, but don't look for anything to be sent to you from Arbo with all the webinars being done for 7 to 10 days. We will also send you a letter of attendance. And that will also take Vanessa probably to the end of the week or early next week. So give everything about a week. Give Arbo a little bit longer time because they're doing a lot of webinars. Joe, did I miss anything there?
No, I don't think so. You covered everything very well. And if you don't mind, I want to take the opportunity to introduce you as our speaker. Everybody, Dr. Greg Caldwell is a 95 graduate of the Pennsylvania College of Optometry, where he stayed to complete a 1-year residency in primary care and ocular disease at the Institute. He is a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, the ABO. Currently works in Duncansville and Johnstown, Pennsylvania as an ocular disease consultant. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease, including glaucoma. He's a fellow of the Optometric Glaucoma Society. He has been a participant in multiple FDA clinical investigations. He's lectured extensively throughout the country in over 12 countries internationally. In 2010, he was the president of the Pennsylvania Optometric Association and has served on the AOA Board of Trustees from 2013 to 2016. And he's president of the Blair Clearfield Association for the Blind. So with that, let's get started with our virtual welcome, Dr. Greg Caldwell.
Thank you. Thanks, Joe, and I appreciate it. And as you know, Joe is a business partner here with Optometric Education Consultants, and truly a pleasure to work with you, Joe. Joe, can you see my screen? Are we working? Maybe you went mute on me already. All right. I'm going to assume that my screen is seen by everyone.
Yes, you're right. I did go mute. I was having mental pina colada. We can see your screen. It looks good.
Perfect. Thanks. All right. We're going to start the education here. We're going to stick to the 50-minute hour, bringing love back to the visual field. And these are the disclosures. Really not too much on here. You're going to see a lot of Zeiss images. I really don't work with Zeiss as a KOL. You can see here I've lectured for Shire, Biotissue, OptiView, Alcon, Allergan. I'm not going to read the whole list. You can see where I sit as an advisory board, PA medical director, telesite consultant, telehealth ambassador. We have our own meetings. Scottsdale, Walt Disney World, St. Paul, Quebec City, Nashville, and I do have that financial interest. So with that being said, here's the question. With advanced imaging in optometry, electrophysiology, OCT imaging, meaning nerve fiber layer, ganglion cell complex, OCT angiography, being able to image the radial peripapillary capillaries and the retina with capillary density around the macula, diopsis, electrophysiology, electroretinogram, visual evoked potentials. With all that out there, do we need to still be doing visual fields, especially in glaucoma? And I know, Joe, that you went on mute there. I'm going to give you a second to turn this on since you do a lot of jurisprudence and medical errors. Have you weigh in on this, on visual fields? But, do we really need this? And the answer is yes. And Joe, if you're on there, do you want to talk about maybe as it being a standard of care?
Yeah, visual fields are still a standard of care in glaucoma. And with glaucoma diagnosis, you need gonioscopy, optic nerve evaluation, stereoscopically, hopefully, threshold perimetry, and intraocular pressure measurement with tonometry. Those are 4 things that you absolutely need. And I can tell you, we're not going to get away from visual fields because sometimes that isn't just glaucoma or only glaucoma, and these imaging tests are actually relatively weak compared to visual field when the patient actually has neurologic disease.
Thank you. So that's a My answer is yes, and there's a strong answer with a lot of background from Joe being a yes. So, and as you heard him say, OCT imaging and OCT angiography and diopsis is not the standard of care. Certainly helps us out, but that's why we want to talk about visual fields. Now, let's talk about the other false positive here, perimetry. So what we're talking about is when you do a visual field, obviously you can get a scotoma, and that's what it says there in the first bullet point. You can get a scotoma. However, the pattern's not repeatable. And if you can teach the person and keep retesting, you can get a reproducible a scotoma in damaged eyes. With that being said, if you can keep testing, you can make that, and the patient understands it, you can make that visual field, that scotoma, disappear. Now, the drawback is once you're outside the normative database, on say an OCT, the nerve fiber layer or the ganglion cell complex, once it's outside the nerve fiber layer database or outside the normative database, you're going to keep getting that same, what we call blue defect, red defect, yellow defect, because these instruments measure into thousandths of a millimeter. So once it's outside the normative database, you can keep testing all you want. That's where it comes interpreting the OCT. So that's when you hear us talk about the false positive. There's a scotoma there. The patient's really not sure what they're doing on the visual field, but if you keep giving it to them and have them test it, you can make that go away. So that's one of the false positives you hear talked about visual fields. Now, the future is exciting for visual fields. Again, it should be done in every glaucoma patient, but just be careful. And this is the exciting part of where visual fields is going. The agreement of where the photoreceptor is and where the visual field defect is, that's why you don't always see that structure versus function. Where they're working on, where I say it's exciting, they're doing targeted perimetry, meaning that they're going to be able to know where that visual field defect is with regarding the nerve fiber layer bundles and the photoreceptors. And that's why you hear us say when you go to glaucoma meetings, discordance, the harmony is high. So where the nerve fiber layer defect is, and is not always where the scotoma is, but that's where the exciting part is where they're coming in with targeted perimetry. So the future is fun. It's bright. They're doing these VR goggles. So it's going to be kind of neat to see where visual fields end up in the next few years. We're going to talk a lot about Humphrey tonight. That's what I grew up on, and I still have that. And this slide here just reminds me of all the different things that have happened. And then I just like it because we all remember, when Stat Pack came out, and then Fast Pack, and then Swap, and then Sita and Swap, and all these things that have happened. And where I want to talk a little bit tonight here is on Sita Faster and Sita Faster 24-2C as some of the newer patterns that are out there. And again, a lot of these, even though it's Humphrey and Zeiss, all the stuff that I teach can pretty much be applied to any visual field that's out there. Real quick didactically here, what I want to point out is just a reminder on the superior visual field. It tests about 60 degrees. You could see 50 here. This is about 60. So it's kind of the superior temporal side is where you get to that 60. And then if you go over nasal, you get to, again, another 60 degrees. And then you hit about an inferior temporally, you get to 75 degrees, and then 100 degrees temporally. So it's just a real quick reminder of kind of how the visual field is 60, 60, 75, and 100, with the macula being the central 13 and the fovea being 3 degrees that's out there. This is a really fun slide here. This really starts getting into some of the things you need to know when it comes to interpreting a visual field. And if we get to the end here, I kind of show you how this kind of plays into almost the very last slide. Most visual fields will test anywhere from 0 to 51. Remember, 51 is the dimmest light that's possible, and 0 is the brightest light that's out there. However, when you look at the human visual system, they should not be able to see 41 to 51 decibels. And that's why it's extremely important. It drives me crazy when I go to lectures or I see professors saying, all you have to really do is look at the pattern, standard deviation. You don't really have to look at total because that's not telling you anything about, because there's media involved and this is just raw data. You have to learn to interpret the whole visual field. I like looking at these numbers because I know what they should be, and they shouldn't be 41 to 51. If they are, the patient's trigger happy. They're just going too much. I like to know where the zeros are because that could be a trial lens defect. So you got to learn to interpret the whole visual field, and that's why we're here tonight. So the first pearl is, if you see any of these numbers up here, 41 or higher, the patient is probably going to see it. You're probably going to see a lot of false positives. The patient's just trigger happy. Now, how about refractive blur in an undilated patient? As little as 1 decibel depression for about every diopter of refractive blur. And why I bring that up is because I test a lot of glaucoma. Joe tests a lot of glaucoma. And we see these patients every 3 to 4 months, and we just sometimes get away from that refraction. So, and these patients have cataracts, and so cataracts can cause a refractive shift. So make sure when you do a visual field, at least your technician is running maybe an autorefractor, looking at their current prescription and seeing if it's within a diopter. If not, it might need a fresh refraction so that that can be plugged in, and so that we don't influence these decibels being measured in the threshold visual field, and then we think the glaucoma is worsening. The second thing I'll talk about here is what about the cylinder? Well, anything less than 2 diopters can be left uncorrected. Anything, and you can do the spherical equivalent. However, once it starts getting 2 diopters and above, you want to start correcting that with a trial lens. Now, we all know that a back of a visual field is lit, and we all went to school and we all memorized 31.5 apostilbs. And when we took our boards test, we always had that the back of a bowl is 31 apostilbs. Why is it lit? Now, the whole idea is that you're basically putting the patient into the photopic or daylight. You're basically isolating the cones here so that you're relying more on contrast rather than absolute brightness. It just makes for a more reliable visual field, and you're taking out some of the influences of pupil size, crystalline lens color, and the transparency that might affect the thresholding. So that's really the main reason why the back of the field is lit. It's putting them in the photopic or daylight, and it's isolating the cones rather than using the rods. Now, static perimetry in eye care, you can use it for neurological disease, retina disease, and glaucoma. And I want to kind of focus on glaucoma, but as Dr. Saka mentioned when we were talking about, should we do this? Is it the standard of care? There are other diseases that the visual field is great for, and they're kind of listed there as retina and neurological. So when you're doing glaucoma, what should we be doing? We should be testing the central 24 to 30 degrees, because only a small amount of glaucoma defects will fall in the periphery of the visual field. So when it comes to glaucoma, the 24 or 30 degrees, that's why you see 24-2s and 30-2 tests when it comes to glaucoma. Again, very few defects fall in that peripheral. And that's where most of the retinal ganglion cells are. However, that's where the targeted perimetry is going to start coming into play, is that now we kind of understand that it's the retinal ganglion cell. If it's positioned in one area, that doesn't mean that's where the visual field defect would be if it was damaged. So that's the targeted perimetry side that's coming down the future here. Now, 24-2 versus 30-2. Which one should you do? There are 54 spots on a 24-2, so there's 54 spots being measured. On a 30-2, there's 76 dots, 76 dots being measured. Now, this is a 24-2. You can see the strategy here, central 24-2. It's a threshold. You can see I have the Foveal on because we're going to be talking about that, and it's a Sita standard. But what I want to point out is it's a 24-2 superiorly. It's a 24-2 or 24 degrees temporally and inferior. But if you look at the nasal side, it goes out to 30 degrees because we know glaucoma generally starts on the nasal side. So when you look at the visual field, it's 24, 24, 24, but nasally it goes out to 30 degrees. So that's why most glaucoma docs will do 24-2 because little diagnostic information is lost. You're saving time and you're not getting those artifact trial lens defects that can occur. So the only downside that I can really find in the literature would be by doing a 30-2, you can sometimes find an earlier progression because you're using more spots. However, the offset of that is that you start getting into the trial lens defects, you start getting into things that can compromise the visual field. So that's why 24-2 is usually the test that's done in glaucoma. This is just a reminder slide that the standard automated perimetry, this is just thresholding. How dim is the light? Remember, 51, which humans can't see, that's the dimmest light out there, and 0 is the brightest light. So that's what I had when I started. And we used to have these 12 and 13-minute visual fields because we didn't have the Swedish interactive threshold algorithm that was out, or what we know as Sita. Sita just optimizes the thresholding and can cut the visual field by 50%. So that's what Sita is. And then that can be applied to your standard automated perimetry or SWAP, which is the short wavelength automated perimetry. That's where you're using the blue and yellow light and back of the bowl. Now, are you a Sita standard person or a Sita fast? Well, you can ask glaucoma docs, and the ones that really get into visual fields and understand it to they say like a really high degree, they'll kind of cheat on the side of Sita standard, and you'll see here why. Now, some of them will go to Sita fast because as the patient fatigues, they can get the test over quicker. Sita fast is only about 33% quicker. So you're not that much. It's 2/3 of the time than what a Sita standard is. And this is why this is why most docs prefer it. Right here, more tolerance of mistakes is the biggest reason, and more precise. It's more precise because it needs to cross the threshold twice to nail down what it's going to be threshold at. So as you can see here, the patient, this is a very bright light. It's within the hill of vision. 24 is the bright light. Remember, the bigger the number, the brighter the light, or the smaller the number, the smaller number, 24. This is a dimmer light, 32. So they can see it. They can see it. Oop, they can't see it. So somewhere in here, it would try and guess on a Sita fast. So then it brings it back down and brings it across. So it crosses the threshold 2 times, and it tightens up where it would say that the decibel of that area being tested. So Sita standard crosses twice, more precise, more tolerant in mistakes. So we talked about Sita standard, talked about Sita fast. What about Sita faster? As you can see here, I had it coming soon. Well, it's here. Sita faster is here. What is Sita faster? Well, it turns off false negatives. False negatives are actually pretty good to be on a visual field. Actually, false negatives are kind of expected in a glaucomatous visual field because if that retinal ganglion cell is sick, what happens is it gets threshold, it sees the dimmest light. If it was healthy, it would recover quickly. But since it's kind of wounded, remember, a retinal ganglion cell in glaucoma just doesn't go on to off. It just doesn't go from being alive to dying. What happens is it goes from being alive to being wounded. If you catch it early enough, you can have it recover. But if you get too far, then it eventually dies, and then you get the scotoma. So in a visual field, if you threshold it, it doesn't have enough time to recover, and you go back and retest it, then it's going to have a false negative. It took a brighter light. Oh, the patient must be falling asleep. No, what we found is that false negatives can be a little bit higher in a visual field. So they turn them off on Sita faster. They turn off the blind spot because, they plot the blind spot, and then the patient kind of settles in, and then they move, and then you get 14 out of 14 on the blind spot. So they would rather use the gaze tracking. But they leave false positives on. If I can leave you with one thing tonight, and I know I started with slide number 1 being false positive. This is a different false positive. This is when people are trigger happy. If someone is trigger happy in a visual field, it just destroys the visual field. There are times whenever I just say to the patient, look, if you're going to do this, please don't anticipate. Don't be trigger happy. Don't try and figure out the test. because false positive really raise that hill of vision and it just destroys the whole algorithm of interpretation with it. So we want it. That's why false positives are on Sita Faster. And they say that Sita Faster has the same reliability that's out there. Now, here it is right here. You can see right on here. Here's Sita Faster. And when you slide over, you can see fixation losses are 0 out of 0. They're turned off. You can see false positives are 13%. That's a little too high. And that's why you'll see here on this visual field, what has happened is the patient was a little trigger happy. And the visual field, because of media, should get better, but it gets worse as we go from total to pattern. It's because the threshold visual field for this 63-year-old person is pretty high. So they tested normal here, right? 33, 33, 33. Those are pretty high, but they're not within that 41 or 51. But what happens is, since they're pretty high and it says, well, let's bring it down to where that 63-year-old person should be. Now, all of a sudden, you can see these 5s and 4s start jumping to 7s and 6. And the trigger happy has brought that is down. So, on the glaucoma, I would maybe ask my technician to maybe do this one again because the false positives are a little high. But what I wanted to point out here is that it's Sita Faster. The false negatives are off. The Fovea, I like for it to be on. So you'll talk about that here in a second. But check this out. 1 minute and 42 seconds to do a visual field. Far better than the 14 and 15 minutes whenever I was doing my residency back at PCO in 1995 and 1996. You could see again, the fixation losses are on, but the gaze monitor is on. And the cool thing about, at least with this programming, is it's Sita standard, but yet it still mixes with the Sita Faster, and you can get all the progression analysis that's out there. So I like Sita Faster. Here's my pearl. I do not start off with Sita Faster on new glaucoma patients. I like doing Sita standard because it crosses the threshold twice. And then when I feel that the patient has graduated, they get the visual field, that's when they get the luxury of going to this quicker and faster visual field that's out there. Maybe not the 4 or 5 minute visual field, but then they get down to the minute 42 visual field. But I like to train them and start them on Sita standard. That's my clinical pearl that's out there for those who are listening. And you can see here, this is a paper by, obviously it's by Zeiss, and they're just saying here that the Sita Faster results are equivalent to the Sita Fast and Sita Standard that's out there for those who have that concern. Now, here's something that's cool that came out. How about the Sita Faster 24-2C? Now, what does the C mean? Well, everything still holds into play here. You still have your fixation losses that are off. You can see this patient did a great job. They had 0% on the false positives. False negatives are off. This is a 3-minute test. You can see the Fovea is on. Remember that number 36 that's out there. Sita Faster strategy. But look, there's this little cluster in a C. There's an extra 10 spots. And we're going to talk about that here in a second. So you can see here, I love this. Look, it's showing up potentially a glaucoma defect here in the center of this patient. You can see this is the left eye and this is the right eye. A few added spots here. So that's the 24-2C. And here is where the opportunity of improvement occurred. Anytime you see Don Hood's name on something, I like to read it. I mean, this guy understands the thresholding of a ganglion cell and how the visual field works and how all these strategies work. So I love reading. And what we know in glaucoma is that the macula can be damaged. And how many of us out there, if you have a clean 24-2, whether it's Sita Standard, Sita Fast, even Sita Faster, how many of you then do a 10-2 to assess that macula? And we know that a lot of people don't. So then that's why this group of docs came up with the 24-2C. So what they're showing here in this cartoon or in this diagram is that the 24-2 is abnormal. And so is the 10-2 would be a glaucomatous defect, but it would also be picked up on a few spots on the 24-2. But check out this 24-2 where it's saying, well, maybe there's a spot here, and maybe there's something being picked up here, but you can definitely get something picked up on the 10-2, and then vice versa. The 10-2 is perfectly clean. So you can't really do one or the other. You should be doing both, 24-2 and a 10-2. So what they decided to do is they got this group of docs together that understand visual field. They looked at the 10-2 and they picked up in glaucoma the 10 points that are most likely to be damaged in glaucoma. And that's how those 10 points got added to the 24-2C, and I'm assuming the C stands for center, or at least the C pattern that it's showing. So it's a 24-2 with not all the spots of a 10-2, but the 10 spots that are most likely to get damaged in glaucoma. So it's a pretty cool test that's out there. You're doing 2 tests in one. I utilize it a lot in the practice now. And you can see here that this is just an advanced case. You can see that that's being flagged. You can see the central, and then when we slide over to the pattern deviation, you could see how the glaucoma is kind of this inferior arcuate with the macula also being involved in this case. This is a pretty fun case here. Check this out. This is a 24-2. We're doing a Sita standard, so we're doing everything. I don't like that the fovea is off, but we do the visual field, and then it adjusts for, you can see it's a 6-minute field, and it adjusts for the media that's out there, and you can say, wow, that's a pretty clean visual field. But when we do a 10-2 or the 24-2C on it, which has those 10 spots from the 24-2, check this out. You could see that this is a glaucomatous case. And if we would have done the 10-2, we would have picked it up. So you could see that glaucoma does affect the macula. It's not always the periphery. It could be the periphery first and no macula. It could be macula and no periphery. And that's why this visual field, this 24-2C Sita faster strategy, I've kind of gravitated to in the practice. Again, here's the left eye of that same patient. Look how clean this is. This is a glaucoma patient of mine, and I was following them within normal limits, 99%, just a mild defect, kind of scattered throughout the visual field. And then when you jump over here, look how the macula is being affected by this patient. So, and you can see that 99 then drops down to 97, and that the defect is a little bit bigger. So vision fields are exciting, right? Remember, there's lots of strategies coming out. We're merging 24-2s and the 10-2, and then now we got VR goggles, and we have targeted perimetry. So stay tuned. You're bringing love back to the visual field. It's only going to get a little bit better in the years to come. So I keep referencing this fovea on. I like the fovea on. Kind of gets the patient warmed up a little bit. And it also lets me know if the patient is understanding the test. And I'm just going to fast forward and advance this slide right here. As you can see, if a patient is 20/20, their decibels in their macula should be around 37. If they have macular degeneration or drusen or maybe diabetic retinopathy, you'll see that start to slide down. And that's why, I think we turn it off a lot of times because we're really not sure what it's supposed to mean. If I see 40s and 51s, right, we know that the patient doesn't get it. There's no way it's outside the human visual system. It's part of the interpretation part. So I like it being on. It should correlate with the visual acuity. If someone is 20/40, it starts to get down into maybe that 34 or 35 decibels. Remember, the smaller the number, the brighter the light. So it had to be a little bit brighter for them to see it because they don't have that 20/20 acuity that's out there. So I like fovea on, and some of my partners in the practice, they don't always push for it. So, technicians will sometimes forget to do it, but I like to push it with the patient, especially, maybe we're looking for plaquenil issues. We can see that being early on, and then we know that the glaucoma can affect the macula. So it's nice having the visual field and fovea on. This is a really easy slide here. Short wavelength automated perimetry, blue, yellow. basically Sita killed that. So, we back in the day, it was reduced redundancy, fewer blue photoreceptors as opposed to green and red. So if they were dying, you could pick things up. It was a Goldman 5 stimulus on a yellow background. Basically white on white, it can pick it up the same or earlier with the Sita standard strategy. So very, very rarely is it used. All right, so let's talk about glaucoma visual field. What do we need? Well, we need a current refraction. Cataracts can cause a refractive shift. We talked about how 1 diopter of refractive shift can affect 1 decibel on the threshold. 24-2 over 30-2, if that's your preference. I prefer a Sita standard, not Sita fast. I like how it crosses the threshold. And then as they get good, then they can graduate to the Sita faster, and Fovea on for the reasons that we discussed just a few seconds ago. So interpreting a visual field, it is no longer considered reliable or unreliable. It's actually a continuum of highly reliable or marginally informative information or marginal information. False positives destroy a visual field. We talked about that. You want to keep the false positive as low as possible. False negatives, we discussed that a little bit earlier. They could be a little abnormal in a glaucomatous visual field because they can't recover, right? I'm not a distance marathon runner. So if I went out and ran a 10K and someone that is trained for it, they'd run that 10K, I'd run the 10K, and I'd sit there for an hour huffing and puffing, as opposed to that person just hops in the car, drives home, and go cuts their grass. So if they're a little bit wounded, it takes a little time to recover. That's why false negatives are a little bit higher on the visual field. Gaze tracker, better indicator than the blind spot. That's out there. And progression, it's not that it's present or absent. We all know that visual fields will progress over time, and some people or most people, it's just is the rate of change acceptable that's out there. So hopefully that slide helps you out. Starting to get into some clinical stuff. So I'm going to start talking about mean deviation and pattern standard deviation here. But just look at this number here. When you look at that mean deviation on a visual field, and we're going to talk about what it is in a blind eye here, but just kind of remember this slide. 5 decibel visual field loss. People read slower. They won't leave their home as much. They walk slower, and they have increased car accidents. So when you look at that mean deviation, we're going to get there soon to kind of help you figure out, well, is that bad? Is that deep? Or is that not? Just remember that number 5, that people read slower, they won't leave their home as much, they walk slower, and increase car accidents. And then when you go into practice tomorrow at clinic or your next visual field, and you have someone that's getting close to 5, remember, we don't want that to happen because these things have been documented. So here's a patient with a severe glaucoma defect. Let's take a look at it. This is from September 29, 2017. The visual field index is down to 61. It's not 100. Look at this minus 14 that's out here. And look right here. Look how deep this is. This is terrible, right? The good news is it's gone in one area and just keeps pounding the heck out of this arcuate bundle right here. And it's the brightest light, and they can't see it. So you're shining the brightest light here, and this patient cannot see it. And Joe, I think this is the first polling question coming up. We have 2 tonight. So everyone out there, get ready on this patient. Hopefully it all works. Or yes, it says polling question number 1. Let's go back. And this patient here with this severe defect, look, brightest light, can't see it. How would this patient see the world? Here's polling question number 1. Go ahead and launch it out there, Dr. Salka. Are they seeing that world as A? Are they seeing it as B, C, or D? And remember, Dr. Salka, I can't see it because I'm in live mode here with my slides. So I'll have to rely on you to kind of see the answers rolling in and then let me know what's going on.
Okay, we have answers coming in. And right now, C is ahead and has been overtaken by B. It's a race between B and C, with A and D taking the pole position. They're coming up.
And actually, Joe, this is your slide that I kind of stole from one of the lectures that we did together, and
That's okay. I stole it from somewhere else.
and I slid it in here. So maybe I'll have you comment on what you think the answer would be, and then we'll talk about it.
Okay. Well, most people think it's going to be B or C. A few people A or D. And that's where we stand. 50% was B, and about 28% was C. And the answer really is, I think, none of the above.
Okay.
People, and I think that this is actually a disservice to the population, because they look at this and it's easy to explain and understand, and they think to themselves, okay, I don't have this, so I'm fine. And they don't see black. What they don't see is they don't see things that are there. The brain fills it in. And what it does is it fills things in like a white snow. So an elderly woman crossing the street, and they see the street, they see the car, they don't see the woman. They don't see black, they just don't see the woman. And it doesn't end well for the pedestrian in that kind of situation. So this is a little bit misleading. They don't see anything like this. What they see is they just don't see things in their visual field. It's not black.
Right. So that was the whole point, is that a lot of people would say, oh, they have this big defect, and they, I wanted to steer away from A or B. Obviously, they're not going to have a normal visual field, but my point here of this slide is, and I got some other pictures coming up that I stole from one of Dr. Salka's lectures here, is that we all know that we have, and we've all done it in school, that we have temporally, because our optic nerves are nasally, we have blind spots, and we've all done that, where we've looked at the one and we can see the little X disappear and we have that blind spot. But we don't walk around with these black holes in our vision because the brain fills it in. And that's what Joe is saying here, is that someone has a full visual field, they see this children, they see the ball, they see the children, they see this car. This is more representative of what the patient is seeing out there. They might not see this patient or these two children running out, but it's filled in. They kind of connect that sidewalk. The car is here, and there's that kind of white snow that Joe was talking about. Your brain just kind of, well, there shouldn't be a black spot there, but this defect is kind of filled in. And check out this advanced defect, where this cars are kind of blurred and your brain's trying to fill it in. You can see the ball, but there's no car here and there's no children. So, when I speak to optometrists, they say, well, do you pull people's licenses? Do you do that? Well, yeah, it's a part of our duty. It's part of our license. But I think, a lot of people come in and they're really not tripping over anything. They're not really complaining of this black vision. Well, yeah, they're not, because the brain is kind of filling it in this way. But look how, in this case right here, look how these children in car could be missed that's out there. And here's another one right here, that there's a patient with this advanced scotoma. They're driving down the road, and this is probably the pedestrian that Joe was referencing here, is that the person that's driving, it looks like there's a building and everything looks okay because the brain is filling it in, but they don't see this car and they don't see this person here. So don't think that they walk around with these black holes. The brain fills in just like our normal visual field in our normal blind spot that we have. And we don't walk around with these two black holes in our vision. Our brain just kind of fills it in. Joe, anything you want to make any comments on that? These are kind of your slides. I just kind of wanted to use that as kind of a warm-up and polling question, and it's part of our regulatory process. Any other comments?
No, you handled it very well, Greg.
Perfect. Thanks. So interpreting a visual field, let's start looking at probability plots for diagnosis and hemifield test for diagnosis. And then staging, I want to start getting into the mean deviation and visual field index. So probability plots, total deviation to pattern standard deviation. This is what we expect. We expect that this 48-year-old person with a 35 macula, so they should be about 20/20. Maybe they're getting the test, maybe they're not, because maybe that should be closer to 37. That's why I like it. The Sita standard threshold. What happens is the total deviation is showing a few spots, and maybe this decrease in the macula is what's causing this 35, that drop to 37. I'm not sure if this is a glaucoma patient, but we're just using this for teaching. And what I'm doing here is showing you how this gets better, maybe due to media, but I'm not sure what type of cataract a 48-year-old person would have. But it gets better because they're not real trigger happy. So then the algorithms within the visual field actually raises the visual field up. And that's why you see these defects get less, because the visual field has been raised rather than depressed here. So that's what we're showing here on this one. I can show you, I can tell you right now without even looking up here at this. See this total deviation? Look how white it is. Look how good it is. 35, 35, 34, 63-year-old person here probably should have cataracts. But what's happening is we're used to, if I go back, the visual field getting better going from total to pattern, but it gets worse going total to pattern. I can look at this here real quick and say, well, it's probably trigger happy. And look what it's saying right here. Abnormal high sensitivity. They have a 99% visual field that's out there. So they're trigger happy. And what it does is it's pushing the visual field down, making actually probably these normally threshold spots showing up as a defect. And that's in the left eye. And the same thing has happened over here in the right eye. Perfectly clean and gets worse. Patients a little bit trigger happy. And of course, if they're trigger happy, they're going to have 100% visual field index. This is the opposite. This is that dreaded butterfly, that clover leaf presentation. Why am I doing this visual field? I could be out doing yard work. I could be going to the bank. I could be doing different things. Does this test really do anything? And because the macula is being tested, yeah, they'll respond to that, but they're zoned out. And so just outside the macula, they just don't see it. So you see all these numbers in here. They're actually a little bit depressed, but then you see all the zeros that are out here. And you could jump right up. They're not trigger happy, right? 3%. They're just falling asleep on this one. This isn't glaucoma falling asleep. And you can see how long the test took. Did they really get the test? 26, 68 years old. Maybe they have something going on as a cataract. But it doesn't look like macular degeneration. They're just not getting the test and falling asleep that's out there. That's that butterfly or cloverleaf visual field. Joe, go ahead and launch this next one. I know what this question is, and it's not coming up for a little bit, but I'm just kind of curious what the audience has to say. So let's do polling question number 2.
All right. What is the mean deviation on a 24-2 visual field if the eye is blind? Is it 0%?
Or 0 decibels?
0 decibels. Is 16 decibels, 32 decibels, or 100 decibels?
So the patient's a blind eye. And what we're asking for is, if you look at my screen here, the mean deviation of a blind eye. Is it 0? Is it 16? Is it 32? Or is it 100? And you'll see where I'm going with this in a second as I get to a slide or two.
Okay, we're getting responses. We have a slight lead at 32 decibels. "32 is still leading, 0 is catching up. Now it is not. All right, and I think what we're going to do is we're going to end the poll. The winner by 26% is 32 decibels.
Okay, that is the correct answer. We're going to do that here in a second. 32%, got it. Correct, still not majority. So let's just look, what does mean deviation mean on a visual field? The simple definition is just how deep is the defect? And the reason why I asked that question is because what is the mean deviation on a blind visual field? I actually walked into the office one day and I said to my technician, hey, Caitlin, can you do me a favor? Go turn the visual field on 24-2, Fovea on, or not Fovea on because they'd have to do the Fovea, but go run me a 24-2, and it's a blind eye, just let it run. Because I didn't know what the mean deviation was in glaucoma, what I didn't want the patient to get to. So the whole point of this whole exercise right here in mean deviation is there's 54 spots. If they were all decreased by 1, this would be a mean deviation. But if half of them were decreased by 1 and they all were totally normal, so half of them were 2 times 27 is 54 divided by 54. All of these instances, all of them being depressed by 1, half being depressed by 2, or a quarter being depressed by 4, it would all still be a mean deviation of 1. And that's where pattern standard deviation comes in. I mean, I went to school and I got all confused what all these things mean. This just tells you how deep it is, and this just tells you how localized it is. And the more localized it is, the deeper. But that's what glaucoma does. It just keeps pounding that same area, and that means it's more localized. So you can look at these two numbers and see how deep it is and see if it's scattered throughout the visual field or if it's just localized. By looking at these two numbers, it's a very mild defect, and it's just scattered throughout the whole visual field because as it becomes more localized, the number becomes higher in pattern standard deviation.
And Greg, going back to that poll, I made a mistake. The real winner of it was, I don't know what the mean deviation is, and I'm glad I'm here to find out.
Perfect. So that's good. All right. So thank you. All right, visual field index, VFI. It's just part of the visual field indexes here. Visual field, there's pattern, there's standard. Mean deviation, we talked about that. Pattern, standard deviation, how deep, how localized. Visual field index, which is right here, this VFI on a Zeiss. It's more of an enhanced mean deviation. It has less effect by cataracts. It's more sensitive to changes in the center part of the visual field. Basically, normal would be 100% and parametric blindness would be 0%. So it's just another indice to show you how deep it is. Remember, a blind visual field is 32. So this is only 2. So that kind of makes sense that it's a 97. All right. So here it is right here. I've done it for you. See, this is a 30-year-old patient that we typed in. They never hit the button. So all zeros. So it registered as 34 in this 30-year-old patient. But look, the pattern standard deviation is low, right? It's low because it's diffusely scattered throughout the whole visual field. And then I did it on a 65-year-old patient, and that's the minus 32. So when I'm treating glaucoma, what do I tell my patients? I never want them to get to minus 32. So now the question is 16 half blind? And the answer is no, it's not a linear, it's curvilinear. And that's where this next few slides come into play here. I did it for you on the new visual field, the Humphrey 3. See, here's minus 33, here's minus 32, 65, 35-year-old patient. So when we're treating glaucoma, we don't want them to get to minus 30 or 32. Now, in talking to the glaucoma docs that are out there, and Joe and I both belong to the Optometric Glaucoma Society, and Joe might even be a founding member of that. And we could see here that we sat around one day and we talked about 0 to 5 is a mild defect. And remember what I told you, when this number gets to 5, people don't want to leave home. They read slower. They have increased car accidents. So next time you go in the office, look, minus 5 is a big deal. 5 to 10 is a moderate defect. Anything above a 10 is considered a severe visual field defect. And then how many decibel difference between these two? If one is a 7 and one's a 10, the eye with a 10 should have an APD in it. But it usually, for me to pick it up, is about a 5. So one's a 5 and one's a 10. The eye that's a little bit more damaged, you should be able to pick up an APD over there. And that's a good way to check the reliability of the visual field and your APD skills. So I know we're getting close to time here. Let me run through a couple cases and interpreting of visual fields, and we'll get it wrapped up. I think we started at about 07. So let me just run into a few visual fields here, and then we'll get it wrapped up and see if there's any questions. So here's a good way of following it. Here's IOPs of 24 and 24, pachymetries, they're a little bit thicker, not going to really influence the pressure. We're not going to get into that, but this is not any really high risk or low risk based on packs. But what did we do here? Sita standard, the fovea is on at 35. That patient has pretty good vision at 65 years old. and the glaucoma hemifield test is within normal limits. Visual field index is good, hardly any defect, and it means it's scattered throughout the visual field. And you can see what has happened over time. They're really not progressing. Sita standard, Sita standard, Sita standard. You could see 99, 99, 99, 0, maybe a minus 0.15. They're really not progressing over all these years. I feel comfortable, at least from a visual field, that this patient is ocular hypertensive and not being treated. And we can see the same thing here. We have another Sita standard on the left eye. The reliability looks good. The fovea looks good. And the defect is just a 0.61, and it's just scattered throughout the visual field. And you can see over time, we're doing well with our, started off at 0.82, we went to 0.1, and now we're back to 0.6. So there's some fluctuation with this patient, but you can see here in 5 years, the progression analysis looks really, really good. Now, let me just show you someone here with a glaucomatous defect. And you can see here that it's a mild defect. Look, minus 3.1. Look how it's becoming more localized. So you can just look at these numbers, and it's a 93 visual field index. So it's becoming more localized. That's what happens in glaucoma. You can see what's happening here. You can see what's happening with the numbers. A little high on the false positives. And we can see here that the fovea is on, and the patient should have pretty good acuity for being 54 years old. Here is what has happened with the progression analysis. And this is really normal. You can see this over time. And this is sometimes an indication that you're doing well on your glaucoma. That actually gets better because you're taking the stress off of the ganglion cells, and they actually do recover over time. So you can see some recovery in glaucoma. Now, you're not going to go back up to 100%, but you can see recovery is what happened. The patient also got a little better at taking the test, I'll say that, but you can also see recovery because you're taking off the stress on the ganglion cells by lowering the IOP. And the same thing here with the patient's other eye, which is not as bad. You can see here 99%, 99, 99, and 99% with this. Let's look at a severe visual field defect. This is a 59-year-old man. I believe the other eye is worse. Remember, look, we're getting to getting close to 5 here. And they did change over time. In these 4 years, they crossed over to that mild defect to that moderate defect. And look how localized. See, all these are just being beat up. These are still pretty good. And that's what pattern standard deviation means. It's getting deeper. It's very localized. This mild defect, which is now a moderate defect, is still super localized. You can tell what's happening here. It's not really affecting up here in this part of the visual field, which is great in glaucoma. You only want it to be in one area. Now let's take a look at the other eye. Look how deep this is. This isn't half blind. This is more than half blind. Remember, 32 is a blind eye. Around 10 is half of a blind eye. So this one is why we're sitting at 59 on the visual field index. Look how localized this is. You can tell exactly where this defect is, and look how nice this is here over time. Here's the visual field 4 years later. They went from a 16 and got better. Maybe it's visual field, or they're not progressing. You can see how localized this defect is. And you can see what's happening over time as we follow this 89 to 89 to 87. You can see here that they still have pretty good acuity with that foveal visual, right? That's right. Glaucoma can affect the macula. So we want to make sure this is on. Look at this minus 5.4. This was a 4.63, and it was a 5.11 that was out there. So let me just click through these real quick, and I'll just wrap up. These are all in your handouts. We're running out of time here. Let me just kind of show you on this one here. This is someone who didn't want to be treated, and then they decided to get treatment, and you can see how they recovered over time. This is a 51-year-old that he didn't want treated, did want treated, and then he noticed his left eye going bad, and then when his right eye started getting damaged, he wanted treated. But I just kind of wanted to show you this right here. This is how you can look at those bumps. This was one of my partners came up to me and said, man, I don't know what happened. Look, fixation is great. The negatives are great. Their glaucoma changed. I'm not sure what's going on. Look at all these zeros. And then look how flatlined this is. The infrared cannot pick it up. And you should have some movement within there. So I said, this is a totally unreliable visual field. Let's repeat it, and you can see what happened here. Things improve. So use these different techniques that we're showing you here. And
Actually,
here's the
Greg,
go ahead.
Greg, go back 2 slides, please. All right.
Right there?
Yeah, right there. Here's a clue or a pearl that you'll pick up. When you have zeros on each side of the horizontal, that's a nasal defect. When I say nasal, it's like nose, or it is a trial lens. You shouldn't have zeros like that, like 1 or 2 zeros above and 1 or 2 zeros below the horizontal. That tells you there's something blocking them.
Yeah, that's another great pearl. Thank you. Yes, right here and right here. So yes, awesome. Great pearl. Thank you. This said reliable, but then that's the other eye. When we repeated it, you could see here 62 went to 68. They did a little bit better on this eye than this eye. Look, 79 went up to 96. So it was just an unreliable visual field over here. So that's why Joe and I are trying to show you some of these pearls and how to interpret the visual field. And these are just visual fields that you can review. I know we're getting close to that 50-minute mark. Let me just show you this one. We'll wrap up on this one. Take a look. See 47, 48, 47, 45. See this right here? This is outside the human vision, right? Look at this. False positive. Patients just going boom, boom, boom. They're clicking away at it. Yeah, they took the test early. Great. When they threshold the visual field. It's a 9-minute test. You can't use this for anything. The 75-year-old with the Sita strategy, the technician should have just stopped it when they started seeing some of these 48s, because they do know that 41 to 51 they can't see. So it was so high that whenever they pushed the visual field down, and these ones that are kind of normal numbers, right? 30, 32, 29, as opposed to these 50s that are up here, it pushed these as being abnormal when they're truly the normal visual fields. And I apologize for not getting through to all the different cases that are out here. Here's the opposite. This is the sleepy visual field, that clover leaf, that butterfly leaf, because they're still pretty sensitive in the macula. But check this out. Falling asleep, 53%. They're not trigger happy. This is the sleepy visual field, or the false negative visual field. So, Joe does a lot of defense work. He teaches medical errors class and jurisprudence. I'll never prosecute an optometrist, but I'll try and help defend them. But I'm seeing a lot of optometrists getting away from visual fields and treating glaucoma. So we wanted to talk tonight about bringing love back to the visual field and making sure you're doing it at least on the glaucoma patient and helping you out with the interpretation.
And
any questions? Go ahead. Take it over.
One of the most fundamental things that we can do. I'm going to go to the chat real quick and try to get a couple questions. There were a couple that came in that were pretty good. Any comments on FDT and if that is less hindered by uncorrected refractive error?
Well, frequency doubling technology, it's using a whole different type of threshold as opposed to using lights. I'm not sure if I'm not sure how it would be affected with refractive error. Joe, do you have any idea with that answer?
It's relatively minimally affected by refractive error. That's why it's a very popular screening technique.
But when it comes down to following glaucoma, I think that it's still kind of out there. I know that there's been some threshold strategies developed, some visual fields out there, and I think it would just be something that, yes, you could use in glaucoma. You just kind of, like any other tool, you just kind of have to use it and kind of learn it to know what's true and what's not true. But I think most docs still like to use threshold as opposed to frequency doubling.
Agreed. Would an OCT ganglion cell check pick up the 24-2C defect?
Maybe. I mean, the answer is maybe, right? That's the old structure versus function that's out there. And that's what we're finding, is that where those retinal ganglion cells are damaged, it doesn't mean that that's where the visual field defect is. So, 24-2, 10-2, GCC, nerve fiber layer, all kind of needed, but That's that discordance that we hear us talk about. How many times have people have sent me stuff and said, Doc, look at this visual field defect, but the OCT looks great. Well, because the damage is not where you expect the damage to be. The damage could be somewhere else. So, so just be careful out there with those 10-2s, those 24-2Cs. Yes, you might pick up some defect on an OCT. You might not see much defect out there because it could be the visual field picking it up first.
And the only other thing I see up here is a request to put the handout back up so they can download. I think it is still available. Is that not correct, Greg?
Yeah. Let me end my stop sharing my screen here. It's the handout is still saying that it's shared. So if you guys will stay on a minute or two here. If you guys go to files, I have a few more things on my end as being one of the lectures, but if you guys go to files, you should be able to see that it says full slides. That's all the slides, and then the 6 slides per page. And you can download both, but it's under the files tab.
I don't think there's anything else to add other than saying, Greg, that was a really great in-depth analysis of pearls on perimetry. And I'm going to conclude by thanking everybody for attending. We appreciate, we know you needed education, and we're going to be putting these lectures on webinars, probably 2 to 3 per month until the end of the year or longer, depending on what COPE does. Hopefully we'll be able to see you live. There are some states that still require live hours, and meetings are indeed going on. And while we enjoy doing this and helping out our colleagues, we are still looking forward to seeing everybody live, and hope everybody stays safe, protect yourself, and good luck in coping in these unusual times.
Let me just remind everyone that Vanessa, our conference coordinator, will send the information to COPE. It will take 7 to 10 days for you to hit your to get notified by COPE. They are definitely backlogged, but luckily COPE is allowing us, and the states are allowing us to do this, these live and webinars. We will also send you a certificate of attendance. That's usually the biggest question I get as soon as this answers. So that's why I wanted to finish with that. And John, I'm going to let you wrap it up again by saying thanks, but I want to thank everyone for being here tonight.
Yep. Thank you very much. Good luck in your practice. Good luck navigating the world, and stay safe.
Bye, everyone.